When we were first planning this event, I remember to visit when I was a little boy, 6 or 7 years old, to our local department store, shoe department, getting shoes for the beginning of the school year. This was perhaps the first evidence I was nervous, because they had a nifty machine there in the shoe department that would do cool stuff. Now, I could read by this point, so I could read what it could do. But they disappointed me gravely by saying, oh no, we no longer use this. In retrospect, that's a very good thing. When I was reviewing the PowerPoint for the presentation coming up, I thought I'm not the only one who remembers it, so I won't say anything more about it. Later on, you'll hear about it and see it. So this is the first of the 2024's two joint Harvard-MIT Club events. And this is a presentation of radiology and modern medicine. Over your lives, you've been on the receiving end of at least one, probably many more medical procedures utilizing radiology. We are honored to have three practicing specialists with us today to give us a presentation on how the role of radiology, primarily x-rays, currently play in current medical practice. Dr. Charles Diana, Diagnostic Radiologist. Dr. Diana is past president and officer of the Harvard Club, and in his spare time he serves as the MR Radiologist for the Shields Healthcare. Dr. Daniel Canaday serves as a radiology oncologist at Beth Israel Deaconess Medical Center in Plymouth. And Dr. Curtis Bacall, MPH FSIR FACR, I have to read this correctly, is an interventional radiologist, professor of radiology emeritus at Tufts University School of Medicine. And quick overview. Since x-rays were first discovered in the late 1800s, the field of radiology has grown and morphed into multiple specialties. It's truly amazing how radiology, in all its different forms, has made so many procedures less invasive, less painful, and greatly improved patient care. So we will please welcome our three presenters today. And we will start with Dr. Charles Diana, Diagnostic Radiologist.
Okay. So this is what I'm going to talk about today. An overview of current status of diagnostic radiology, some comments on the history, and some brief speculations on the future. My slides are all going to be black on light gray because imaging in radiology is by far shades of reading black, white, and shades of gray with very little color put into it. So this is my work history. I've been on the Cape for 37 years, first at Cape Cod Hospital, and in about an equal amount of time reading MRI for Shields. To start off, I thought I would show you the very first x-ray image that was ever done. This is the x-ray of the hand of the wife of Wilhelm Röntgen, who was the first one to discover x-rays in the late 1800s. And we'll get into plain film, what we call plain films, and other people might just call x-rays. This is like a chest x-ray or a hand x-ray or something. And the ways these are developed, the way these occur is that x-rays pass through body parts to create images, and the images are based on differences in tissue density. So air comes out black and bone comes out relatively white. Some current common uses for plain films. In the ER, chest x-ray looking for congestive heart failure or pneumonia, for example. Screening for lung cancer, although it's not as good as a CT scan for that purpose. They will often get routine daily portable chest x-rays in the ICU to look at the status of the lungs, check positions of catheters, ET tubes, and other devices. In the musculoskeletal range, you get x-rays to look for fractures, for example. Abdomen, we used to get x-rays for abdominal pain, but that's largely been supplanted by CT scans. And then spine x-rays often are done in chiropractor's office Usually more advanced imaging of the spine with MRI often done. The advantage and disadvantage of plain films, advantage is that it's relatively inexpensive, it's fast, it's portable. They can bring these units up to the ICU and get portable chest x-rays. Some of the disadvantages are limited diagnostic value when there's a little bit of radiation exposure. So this is just a normal chest x-ray, a PA and lateral, lungs, heart, and not like this. This is a pet peeve of mine when I would see some TV shows and movies. They have the x-ray upside down, or the image of the wrong body part, or it's bad. So keep an eye out for that. So in the early 1900s, an improvement was developed, a method to view x-ray imaging moving in real time. And this is not x-ray gogs, which some of you may remember, but fluoroscopy. So with fluoroscopy, the radiologist could see images in real time. Commonly, this has been used in the past for barium studies, upper GI, barium enema. Those have been largely been replaced by endoscopy and colonoscopy and CT and MRI techniques for looking at the small intestine. Currently, it's used in interventional radiology for angiography, for example. It's also used, still used, I believe, for swallowing studies. People who have difficulty swallowing. They do fluoroscopy to see their swallowing function. One downside is that it can produce a fairly high radiation exposure, especially in interventional procedures if they're fluoroscoping one spot for a long time. So this is probably my most important slide. Advances in computer technology and data storage, as it has affected the rest of our lives, has also had a big effect on radiology. It's allowed for development of advanced imaging techniques such as CT, MRI, ultrasound, PET scans, and very importantly, they've been able to develop PACS, which is picture archiving, a communication system, which means that radiologists now are viewing images on a computer monitor rather than on film. And this allows for you to view many, many more images. When I was at Cape Cod Hospital and we just had film, we would put a CT scan would have maybe 13 or 14 images and they'd put it on 1 or 2 sheets of film. Film could hold anywhere from 12 to 15 images depending how you formatted it. And we could usually get a CT head on 1 piece of film and we'd get a CT abdomen and pelvis on 3 or 4 sheets of film. And that was maybe 40 images. Well, now there are MRI and CT studies that have well over 1,000 images, and if you're going to try to put them on film, it would be virtually impossible. So now, instead of looking at something on a film, we look at it on a computer monitor, we scroll through the images, and you can look at a lot more images that way. The ability to put images on the computer and send them on computer monitors also allows referring doctors to now view the imaging studies in their office, and they don't have to come down to radiology and try to get the films. It's also started a whole new industry called virtual radiology, where radiologists have monitors set up in their homes, and they view studies that were done in different parts of the country or even in different countries. And initially this started off primarily as a way to help the local radiologists with their on-call stuff at night, so they didn't have to get up and look at something at 2 in the morning. So it was handled by the virtual radiology company. And as time went on, the virtual radiology companies got bigger, more radiologists, and they have branched out. They're reading studies done 24/7 now. They're issuing final reports as opposed to just preliminary reports, so virtual radiology is a big industry now. Finally, in computer technology, we now use almost exclusively voice dictation. We don't use medical transcribers anymore. Voice dictation, you dictate and it comes on the computer screen, and you can read the report while it's still fresh in your mind, make any corrections, send it off, and it's immediately available to the referring physician. So the ultrasound is the first imaging modality that I'll talk about briefly. It came into widespread use in the 70s and early 80s. The images are generated with high-frequency sound waves that reflect off soft tissue interfaces in the body. One of the main advantages to ultrasound is there's no radiation involved. It's portable. They can take it to the ICU. They can take it to the ER, scan patients there. It can scan in any plane. The technologists can turn the transducer and scan in any plane. It's fairly good at differentiating a cyst from solid mass unless the cyst has a lot of junk in it. And one of the few times we see color in radiology is color Doppler for blood flow, red or blue depending on whether the blood is flowing away or toward you. Some disadvantages of ultrasound is, one is it's very user dependent. So if your technologist is not very good and they don't see the tumor in the liver, it's not going to get detected. It also cannot scan through air or bone. Some of the main uses for ultrasound right now these days, obstetric is one of the big uses. It is the king or queen of obstetric imaging. It's almost all obstetric imaging is done with ultrasound now. Also gynecology, uterus and ovaries. It's the first study. Lower extremity deep venous thrombosis it's the first study, and it's replaced venography, which was an invasive procedure. It's the primary imaging modality for thyroid, for testicles. For breast imaging, it's a problem solver after mammography. Mammography finds a mass, or it looks like it might be a mass. They'll go to ultrasound and see whether it's a solid mass or a cyst. It's for abdomen, it's primarily used for looking for gallstones, right upper quadrant pain. It does provide one way of imaging the brain that, other than CT or MRI, that is in the neonates. They have, the skull is not yet fused, they have the soft spot on the top of the skull, and you can put a scanner on there and you can actually see the brain in neonates. And they often use that in preemies to look for hemorrhage. So next we'll get to CAT scanning. CT scanning or CAT scanning became available in increased use in the 70s and 80s. It, for the first time, allowed for directly visualizing the adult brain. It improved visualization of lungs, bones, and abdominal organs. CT imaging uses X-rays, so there is radiation exposure. It's an array around the patient, and the images are based on density differences of tissues. Primary uses for CT scanning these days. One use is it's a screening imager for the brain in the ER to rule out hemorrhage in acute stroke patients. So if someone thinks they're having a stroke and they get to the ER within 2 or 3 hours, they want to use anticoagulation to try to prevent the stroke from spreading or even correct it. And they can't use anticoagulation if there's hemorrhage in the brain, if there's acute hemorrhage. So they do a CT scan right away. CT scan is very good at looking for acute hemorrhage, and so that's one of the uses. In chest imaging, it's currently the best imager of the lungs, looking for small lung cancers, for example. Also for pulmonary embolism assessment, it's you use dynamic contrast enhanced CT scan. It's used sometimes for abdomen and pelvis imaging, acute abdominal pain in the emergency room to look for appendicitis or kidney stones. It's used spines and bones to look for fractures. If you have, say, an MVA, a motor vehicle accident, and you go to the ER and you have neck pain, they'll get a CT scan to look for a fracture. And then used for vascular imaging, CT angiography. So here's a couple of CT scan images. This is brain, axial image of the ventricles, the gray matter, and just try to keep that in your mind, because later you'll see an MRI and you'll see much better detail on the MRI. And this is actually the same image, but just windowed differently. This is windowed so you can see the brain, and this is windowed so you can see the skull. They didn't have to take a different image. So next, MRI, which I've been currently doing for the last 17 years. It came into use primarily in the 80s and 90s. It's been continually improved since then. The imaging is done with a combination of strong magnetic fields and radio frequency pulses. There's no radiation. But because of the strong magnetic field, it's incompatible with some implanted medical devices. For example, most cardiac pacemakers. This is improving though, and there are some cardiac pacemakers where they will allow it to go in the MRI machine under certain conditions. Some patients may experience some claustrophobia, but it's really not that bad. I've been in the machine, it doesn't bother me. The scans take 10 to 45 minutes. They are significantly degraded by motion and degraded by metal in the patient, which is also true for CT. And both CT and MRI can use intravenous contrast. CT contrast has a greater propensity for allergic reactions. You can get a serious allergic reaction in CT in maybe 1 in 1,000, a few in 1,000 patients. MRI contrast is a lot safer and very, very rare reactions to MRI contrast. Many, many uses for MRI. MRI is the primary imaging modality for many uses. It's the best imaging modality for the brain and the spine. In the abdomen, it's excellent for the major abdominal organs, the liver, the kidneys, the spleen, probably better than CT in most cases. And we use this technique called MRCP to look at the bile ducts. In the female pelvis, it's not the primary imaging, but after sometimes if ultrasound has a question, they will go to MRI to look at the uterus and ovaries. And prostate cancer, over the last 5 to 8 years, it's been developed, and it's now the primary imager for prostate cancer. More uses for MRI. Musculoskeletal, it's the best imager for joints, knee, shoulder, hip, wrist, elbow, ankle. Bones and bone marrow, ligaments, tendons. MRA angiography, vascular imaging, you can do with or without contrast. Breast MRI, they do for patients with dense breasts or as a problem solver after mammography. And cardiac MRI has some uses. We don't do that at Shields. So I have some MRI images to show you. This is a knee, and over here is a normal anterior cruciate ligament. And over here is a torn anterior cruciate ligament. Here's the tear right here. And this is another knee. This is a child, because you can tell because the epiphysis is not yet closed. And this is a very important feature of MRI, is you can find bone marrow edema, which is this bright area here, over here. And that usually indicates bone injury, and it's something that you would not see in any other imaging modality. You won't see bone marrow edema or plain film or in a CT scan, or certainly not an ultrasound. And that's often, we'll see bone marrow edema, and that will be the cause of the patient's pain. You wouldn't be able to find it with anything else. And sometimes associated with the marrow edema is a fracture, which you can see is this dark line going across there. And you probably would not be able to see that on the plain film. So this is another knee MRI. Here's a normal meniscus over here. The meniscus acts to cushion between the femur and the tibia. And over here, there should be a medial meniscus, but it's not there. It's been torn, and it's out here in the middle of the knee. Here's a lower lumbar spine. One of the causes for lumbar spine pain could be a disc herniation. Here's a normal disc here. Here's a herniated disc here. And here it is on the axial image. And this is another cause for back pain, is a compression fracture. And again, bone marrow edema. This bright signal here in this compressed vertebral body indicates that there's bone marrow edema, and that indicates that it was a recent compression fracture. And the reason that's important is because that can be treated with vertebroplasty, while a chronic compression fracture, generally vertebroplasty won't help. This is another, this looks like bone marrow edema, but actually this ends up being a tumor, probably a bone metastasis. This is a soft tissue mass going back into the spinal canal from this bone metastasis. So another cause for back pain. Some causes for cervical spine pain. This patient has a combination of a disc herniation and posterior ligament thickening that's causing compression of the spinal cord. And the spinal cord is best imaged with MRI. You can barely see with CT, and you can't, of course, with plain films. Another cause for cervical spine pain, again, we see bone marrow edema here. This is a facet joint. There are paired facet joints in the back of the cervical spine, and they often get arthritis. When the arthritis gets inflammatory, it can have bone marrow edema and adjacent soft tissue edema, and that can cause neck pain. This is a brain, a sagittal T1 weighted image of normal brain. This is a T2 weighted axial images of a normal brain. And if you recall the CT, you can see much more detail here. This is another brain with contrast, and there's a little tumor here. And that was a metastasis from a lung cancer. This is another brain with contrast, meningioma. This is an extraaxial tumor. It's lighting up here and here. Meningiomas often don't need surgery. They're usually benign tumors, often don't need surgery. Depending on size and location, they may need to be operated on, though. Often they'll just be followed, though. Prostate MRI. Here's a normal prostate over here. This peripheral part, this is the prostate gland. This is what they call the peripheral zone back here. This is the rectum back here. But this peripheral zone on T2 weighted images is normally bright like this. And cancers often will show up as a dark spot in the peripheral zone like we have here. And unfortunately, our scans don't come with arrows on them. Here's a shoulder MRI. This is a normal rotator cuff. The rotator cuff is a group of tendons that allows you to do this. Here's a torn rotator cuff here. Next, we'll move on to briefly to nuclear medicine and PET scans, which are related in that the imaging is done by injection of a radioactive element attached to an organic compound, which accumulates in certain body parts, and then is detected by either a flat screen in nuclear medicine or an array like CT scan has in PET imaging. An example of nuclear medicine, the most common use of that is a bone scan, which uses technetium-9Nm as the tracer, and it's attached to MDP, which goes to bone. And that goes to metabolically active bone. It's primarily used to detect bone metastases. For PET scanning, the most common PET scans came into use in the 1990s. Usually now they're fused with CT scan to improve tracer localization. And I think I have more detail on PET scanning. One of the major uses is to look for cancer or metastases using FDG, which stands for fluorodeoxyglucose. FDG is radioactive fluorine-18 attached to a glucose molecule. Glucose is taken up by metabolically active areas, and metastases, cancer is metabolically active, so they will light up on a PET scan. Other metabolically active areas, for example, inflammation, might produce a false positive. There are other radiopharmaceuticals that are used for PET scanning. It's now also used to help diagnose Alzheimer's disease, which I won't go into any detail, but that's improving. Here is some images of a PET scan over here and a PET scan fused with a CT scan here. There are some structures that normally light up, including the heart, the liver, the kidneys, and the bladder, but this is abnormal here. This is metastasis in the femoral neck. Briefly about breast imaging, mammography is the mainstay of breast imaging, and ultrasound and MRI are adjunctive imaging modalities for the breast. And as far as speculations on the future, artificial intelligence is something that we're using to a limited degree now. It started off in mammography. They would do digital mammography, and then they would have a computer examine the mammography and highlight certain areas that they thought that the artificial intelligence thought might be suspicious, and the radiologist should have a particular look at. And they also, I believe they're doing that now with CT scans to look for lung nodules, look for lung cancers. But that will continue in the future. And at some point in the future, maybe, there will be artificial intelligence who will interpret an entire exam without any oversight from a human being, but I'm not aware of that happening yet. So my job is secure. PET scans, we will develop continually new radiopharmaceuticals, expanding PET scan, and functional MRI scans, perhaps based on function rather than just on anatomy. That's probably at its infancy right now, but it's happening, I think.
What is that functional?
It's using MRI to see what kind of, where the brain is functioning rather than just what it looks like. We will have, I think we're going to have questions together afterwards.
Yes.
And the next speaker is Dan Canaday.
Yeah, so I'm a radiation oncologist. In general, my department tends to be this black box in the hospital. Nobody knows what goes on inside. A lot of people have never been in a radiation oncology department, but the fact is that statistically speaking, about half of the people in this room may be dealing with a cancer diagnosis sometime during their lifetime. And about half of the people who are diagnosed and treated for cancer can end up having radiation oncology as a part of their treatment during that course. So it's something we like to at least have people aware of what we do. And today I really want to focus more, since this is partially an MIT crowd, about the technologic history of radiation oncology to give you some sense of kind of where it came from and how we've developed, and more important, where we're going in the future. So as Dr. Diana pointed out to you, Wilhelm Röntgen discovered X-rays in 1895. It wasn't very long after that before somebody started to think, well, what else can we use X-rays for besides taking pictures? So this was sort of the Wild West era of radiation oncology for the first 20 or 30 years, where they would basically point an X-ray machine at something just to see what happened. And the first reported use of X-rays for cancer treatment was only 2 years later. And as a lot of people probably know, Röntgen won one of the first Nobel Prizes for physics for his discovery. But like I said, the development took decades to kind of figure out how to use radiation as a therapeutic modality, because you've seen what it can do to take incredible pictures and imaging and help to diagnose disease, but radiation itself also has an intrinsic anti-cancer effect that can be exploited to treat many, many different types of tumors. So a lot of the original studies in this were happened in France and in England, and they found that the tumors that were most sensitive to radiation were those that had a high mitotic index. That means the tumors that are dividing very rapidly. This couldn't be, they didn't understand the mechanism of this for many decades afterwards until DNA was discovered, and I'll touch on that very briefly. But this is the same principle behind standard, or kind of now the more old-fashioned chemotherapy. Tumors that divide quickly are the ones that are most sensitive to chemo, and also the ones that are most sensitive to radiation. What they also found is that you can cause a lot of damage with radiation. Some of the original studies show that you can sterilize the testis of a ram if you give them a very large dose of radiation that causes severe skin toxicity. But then someone had the thought to say, well, what if we break it up and give it in small increments? So if the dose is fractionated, if you give it a little bit at a time, you can still get the same therapeutic benefit, but the side effects are much, much less. And that's the basis behind modern radiation oncology. If you come in for radiation treatment, there's often a program of radiation where you might come in daily, and it's given like Monday through Friday, 5 days a week, where you get a small dose of radiation each day. And the reason for that is that it still has the same beneficial effect on the tumor, but the surrounding tissue, the normal organs around the tumor are able to tolerate that radiation much, much better. So with the discovery of DNA in the 50s with Watson and Crick, and after that, it was discovered after that the effect of radiation is through direct effects on the DNA itself. Radiation does not work through a thermal effect. There's no heat involved, even though some of the units that we use to measure it are the same things we use for heat. So there's two main effects, one that we call an indirect effect, where the effect of radiation is that it can produce free radicals in water. It breaks apart the water molecules into something called hydroxyl and hydrogen ions that are then able to interact with the DNA and cause damage. A lesser effect is that the electrons that are created locally can cause damage to the DNA itself. So it's a DNA effect, so as you can imagine, that the tumors that are dividing very rapidly do not have time to repair that DNA. That's why normal tissue has a very powerful innate mechanism for repairing DNA, where normal tissue is able to repair itself, but tumors are much, much more sensitive to the effects of radiation. So how do we measure radiation? People I've treated a lot of patients over the last 25 years, but a few people ask me, well, how much radiation did I get? And we use a unit of measurement called the gray, and it's named after, as are a lot of the basic units of measurement in physics, after one of the discoverers in this field. But a gray is measured as an amount of absorbed dose in human tissue. It's 1 joule per kilogram. And for my MIT and the physics and math people from Harvard, you know that a joule is usually a measurement of energy, but again, this is not a thermal effect, it's just a way to convey how much energy is deposited in the tissue, because we need some way to standardize how we talk about radiation. So a very typical dose of radiation, if someone's coming in for treatment, is they will get a dose of 2 gray per treatment, and you might do that over 6 weeks, and you get 30 treatments, and that's a total dose of 60 gray. Anyone who works in physics or in the nuclear power industry or radiation safety would be scared as hell when they see numbers like this, because this is far, far higher dose than you would ever be permitted to be exposed to in the normal course of working, even at the local nuclear plant or what have you. 2 gray, for instance, a 2 gray dose, if it was given to the whole body, could be deadly. So the whole point of radiation oncology is we take what can be a very dangerous mechanism, but we're able to control it, we're able to focus it, and we're able to give it in a very, very precise way, so we can exploit the effects of radiation without causing the danger that uncontrolled exposure would cause. So one of the key things about radiation is that the energy of the radiation is very important. Those original X-ray machines, the X-ray machines that Dr. Diana was talking about, they're measured on what they call kilovolt energies. They produce a type of radiation that's usually between 70 to 100 kilovolts. The limitation of that is that this is a graph of the amount of energy of the radiation and how far it is able to penetrate under the skin surface. So if you have those early X-ray machines that are producing a 100 kilovolt beam, they're really only good for treating things that are right on the skin surface. That's why all the original tumors that were done were basically moles or skin tumors or superficial tumors. And we actually have therapeutic machines now that exploit this, that we use just for treating skin cancers, but they're basically useless if the tumor is more than, say, 1 centimeter or 2 centimeters an inch deep under the skin. So a lot of the development of radiation therapy in the early part of the 20th century was to try to develop machines that could produce higher energies, because the higher the energy of the beam, the deeper it can penetrate into the tissue. So if you want to treat something like a lung tumor or a brain tumor, you have to have an energy that will allow you to produce a beam that can get into where the tumor is. So the original machines, again, the first X-ray machines were 100 kV. Someone had the idea that, well, you can take radioactive sources. There's a very powerful radioactive source called cobalt-60 that produces about a megavolt energy. And you can put that into a machine where basically you've got a cobalt source up here and it produces a beam of radiation. And that works just fine. So the original types of radiation machines were based on the physical principles of just sticking a radioactive source. You put a lead box around it, you cut a hole in it, you open the hole, the radiation comes out and you close the hole. But it was not very sophisticated in how you could deliver the treatment. And obviously you were still limited to a relatively low energy. So it was really in the early part of, again, the 1900s, the 1930s, 40s, around the pre-war and war eras, that people were developing machines that could develop higher and higher energies. So the cyclotron, Ted Lawrence out at Berkeley, the cyclotron was very important for the Manhattan Project and able to separate isotopes of radiation for the development of the bomb. The Van de Graaff generator is a generator that's able to produce very high voltages. A lot of you have probably seen there's a Van de Graaff generator at the Museum of Science up in Boston, where they give that incredible electric lightning show. That wasn't made for show. That was a working machine for many, many decades. It was donated to the Museum of Science when its lifetime came to an end. But even when I was first in residency, we still had areas where Van de Graaff generators were used to produce high voltage to give therapeutic treatment for patients. The limitation is there's only so much of an energy you can develop with any kind of these, like a Van de Graaff generator, before you start to have sparks, before the energy field will break down. So if you want to get into the 10 megavolt to 20 megavolt range that we really, really want to treat people with tumors, you have to get a lot more creative. And again, these machines were also massive. If you've seen that one at the Museum of Science, it's 3 stories tall. It doesn't really fit itself into a small clinic where you can develop treatment. So a lot of the development then became on looking at different ways of producing high energies. And some of the similar work was done in England and in this country during the war years. In California, the Varian brothers developed something called a klystron microwave generator. So this produces a radio frequency wave, but it can be a very, very high amplitude, very powerful. And there's also something called the magnetron that people might have heard of. The whole radar development that happened in England, they developed this thing called a magnetron that was able to produce microwave energy. They then surreptitiously brought it over to the United States when the war started so it wouldn't be lost to the Nazis, and it ended up at MIT where they did a lot of the seminal research on radar that a lot of people have probably heard about. The Varian brothers went on to found this company called Varian Associates, and most of the radiation oncology equipment that we use in this country is now Varian equipment based on that company. So the original linear accelerator was developed by them at Stanford. The way it works is that there's an RF power generator, the klystron, and there's an electron gun. So the electron gun produces electrons that are then accelerated along this waveguide. And it's done in small batches of electrons because this is an alternating field. But if you time it right, what you can get is the electrons are accelerated from one waveguide to the next waveguide through this thing called a cavity. And with this, you can generate energies of up to 20 to 25 megavolts. Now it's an electron, so we want to convert that into a photon. So what it does is it goes around this bending magnet and then it hits a target that then produces photons. And this is built onto a gantry system that can be rotated around an axis, and it's on a machine, on a table that can be controlled very, very carefully. So this is still the basics of any radiation treatment that you would get today. What it does is it allows you to miniaturize this linear accelerator. I mean, there's a linear accelerator at CERN in Switzerland that's 5 kilometers long. This one is only about a meter long. So we're able to generate very, very high energies in a very, very small space. And this is still the basis for what we do today. So the first patient they treated in the mid-50s was a small boy, and everything since that time has been to try to, we've got the energy now, so what can we do to make the treatment more accurate? So the things that we've been doing over the last 50 to 60 years, and including a large portion of my professional career, has been the following. We want to delineate the target, and for that we need our colleagues like Dr. Diana that can help us to focus on where the tumor is. So you'll see a lot of the things that he was telling you about exploits for CT imaging and MRI imaging, we've exploited for radiation oncology to help us focus down more carefully onto where these tumors are. Focusing the beam, trying to be as accurate as possible where the beam is delivered. Accounting for tumor motion, as you may have noticed, your body is moving all the time, especially, I'll show you when we're treating a lung tumor, that's a moving target, and you have to take that into account when you do the planning. Obviously, we want to be as accurate as possible, and the bottom line about this is I can cure any tumor with radiation. The problem is you can kill the patient doing it. So the thing is that you want to be able to give as high a dose as possible, but as accurately as possible, and to protect the normal tissue around it. So that's really been the holy grail of radiation oncology over the last 20 to 30 years. So, the original machines were basically point and shoot. The best we had was you could take an X-ray and you could kind of have a gestalt about, well, I think the tumor's here. This is somebody with prostate cancer. They might give a little bit of dye to try to help you delineate it, but you had to draw a big box around where you thought the tumor was, and everything inside that box got a huge dose of radiation. So that's really what limited how much radiation you could give safely. Because if this is a lung tumor, and if you're given a treatment from anterior and posterior, well, yeah, you can give the tumor a high dose, but you're going to treat everything around it to the same high dose, and you can only give so much radiation safely in order to do that. So when CT planning came along, we jumped on that. I mean, I was still doing this when I was in residency, and that was 1999, 2000. When 3D planning came along, well, we're able to now delineate a tumor much, much more carefully, and we're able to focus the radiation as a result, because we know exactly where that tumor is. So what that developed is the era of what they call 3D conformal therapy, where this is a CAT scan of somebody with prostate cancer, and what you can do is, well, you can give multiple beams from multiple different directions, so you can exploit the fact is where those beams intersect, that's the area that's going to get a high dose of radiation, and you're able to relatively protect everything around it. So this was a huge leap forward. So by doing this, we're able to now give higher doses of radiation, therefore, and do it more safely, so our cure rates are going up. And really, one of the ways we do that is that the way that the beam just comes out is this large beam from the linear accelerator. So we have a technique where we have these collimators, we call them, that are able to block and shape the beam. So we can shape the beam into any particular beam that we need in order to address the target that we're treating. What where that has developed into is that you can actually use that effect where if you've got a radiation beam coming up and down here and you've got these collimators, you can actually move them at different rates. So if you can imagine, if you turn on a flashlight, everything in front of you is getting the same exposure. But if you can modulate the beam, if you can slowly move these apertures across the radiation beam, but stop and let it sit at this level right here for a little bit longer than it does over here, well, then you can modulate the beam. You can give a higher dose of radiation here than we're giving over here. And that allows you to suddenly get very creative and shape the radiation exposure in a three-dimensional way. So with what we call intensely modulated radiation therapy, because we love acronyms, IMRT, if you're doing three-dimensional therapy, well, I'm giving a dose from here and from here and from here, so everything in this region right here is going to get the same dose. But if I can modulate the beam, if I can give a little bit more here, a little less here, and do it over here and over here, well, here I've got a tumor, and say that's a spinal tumor, and say this is the spinal cord right here, well, now I can give a very high dose of radiation to the spinal tumor, but I can give a relatively small dose to protect the spinal cord that's surrounded by this tumor. So this is pretty much the standard of care now for radiation for anyone going through treatment. And again, the other things are, as you would imagine, accounting for tumor motion. Well, if you've got a lung tumor here, it's going to move up and down when you breathe. So remember, precision is not the same thing as accuracy. I can give a very precise dose, but if the tumor keeps moving out of that area I'm treating, I'm wasting the time. So what we do now is we can do what we call four-dimensional planning, where we take into account this tumor motion when people are going through the treatment planning part of this, and then I can make sure that the tumor is never going to be outside of the area where I'm giving the radiation, or I can actually track it, and when it does move outside of that area, well, we'll stop the treatment for a few milliseconds, and then when it moves back in, we'll turn it back on. And we do that because the radiation machines we have now have built-in imaging systems and imaging sensors where we can actually detect and monitor these things in real time while people are going through treatment. There's another technique we have now where there's a special computer system that actually projects a special pattern onto the surface of your body. So if you're coming in for radiation treatment, if you're laying on the table, this machine can detect within less than a millimeter exactly how your body's positioned. So if you move even a small amount during your treatment, the machine will stop. So that's one of the safeguards we have to make sure that the radiation is being delivered to exactly where it should be going. And what this all leads us to do is to be able to give very, very intense doses of radiation to a small area. So really a lot of the developments in my field over the last 5 to 10 years have been something called stereotactic radiosurgery, which isn't surgery at all. It's really meant as an alternative to surgery. What that means is we can give very, very high doses of radiation to a very small volume, and we can do it to an accuracy of less than 1 millimeter. So what we do this most commonly for is small tumors within the lung, small tumors within the brain, people that maybe aren't candidates for surgical resection of a lung tumor or neurosurgery. And I'm able to get doses that are 10 times what I could give using traditional methods. And the advantage of this is that you can give a very powerful amount of radiation. It's totally non-invasive. And instead of coming in sometimes for 5 or 6 weeks, these are sometimes done over the course of 3 to 4 days of treatment. So this has become a major, major part of my practice, especially in the last 5 years. So in summation, treatment in 2024 looks like this. You come in, you lay down on a table, you're on a special couch that has what we call 6 degrees of freedom. We can control this to within a millimeter accuracy in any dimension. The machine delivers a beam of radiation from this area. There's a targeting system that it can actually monitor you and take x-rays of you while you're getting through the treatment. So we use CT-based planning to account for the tumor motion that you might have. We use we can pick the energy that is most ideal for the treatment plan that we have, and we deliver it using that intensity modulation. We have real-time onboard imaging, what we call image guidance, radiation therapy, to guarantee accurate setup and to make sure that we're always tracking the tumor to make sure it's being treated properly during therapy. We have the surface guidance techniques that allow us to just monitor the surface of the body. Where that's very, very helpful is when we're treating brain tumors. When I started treating brain tumors 20 years ago with radiosurgery, there was a special device that we had to have the neurosurgeons come in and implant on the patient, which you've probably seen like surgical collars for people that have neck injuries, where there were actually 4 small pins that went into the skull. And this provided a stable base to keep someone from moving during the treatment. And it was not comfortable, it was not pleasant to go through. It was an all-day affair where they would put the frame on at 6 in the morning, we would do the planning, we would do the treatment in the afternoon, and then we would take the frame off. But now we can achieve those same levels of accuracy just using a simple mask system where the system monitors the surface of your head while you're doing the treatment, and we can get the same level of accuracy. And more importantly, again, we can deliver very high beam rates, delivering to less than a millimeter of accuracy. So more and more of radiation oncology is becoming, how can we do this quickly, how can we do this safely, how can we do this with minimal discomfort and minimal side effects to the patient. A lot of what we still do is still coming in every day for several weeks and perhaps giving chemotherapy along with it, but we're trying to get farther and farther away from this and make it as easy as possible for doing it. So that's Radiation Oncology 101 in a nutshell, so I appreciate the opportunity to be here.
Can you say that last
I
statement?
appreciate, as a former crew member at MIT, we always were a little jealous of the small liberal arts school up the river, but it was fun to have you guys come by.
Could you